Good evening, everyone. Before we begin today's session, I would like to take a moment on behalf of our ACE family. We are deeply saddened to share that Mr. Shrikant Yatnale, our joint treasurer, and Mr. Sanjay Yatnale, the executive member of ACE, lost their beloved father this morning. Our thoughts and prayers are with them in their this time of grief. And we stand with them and pray for the peace of the departed soul. With this in mind, we continue with our today's session, carrying Yatnale family in our thoughts. Let us dedicate this session to the spirit of learning, unity, and strength of our ACE family. Now, let's proceed with today's discussion. I welcome you all to this thought-provoking ACE webinar, a space where science, clinical wisdom, and real-world experience converse. As success rate in reproductive technology rise, so does our responsibilities. To aim now we don't aim just for pregnancies, but for the safer singleton births. Elective single embryo transfer reflects this shift. Backed by the global evidences and a strong lab protocol, it balances safety, ethics, and success. Yet, real-world application demands both clinical conviction and embryological precision. Today, we gather here to reflect upon a question that goes far beyond the number and data. Elective single embryo transfer, is it idealistic or practical? So without much ado, I would like to request our President of ACE, Dr. Sujatha Ramakrishnan, to start the session with her welcome address. Over to you, ma'am.
Thank you very much, Dr. Manisha. And I welcome you all for this journal club. As Dr. Manisha had mentioned, we are choosing topics which will be of interest to all of you, not only just the clinician, the embryologist, but we're also keeping the clinicians in mind, because we know that there are many clinicians around there who want to know more about embryology and then what embryological parameters would have an impact on the outcome. So our choice of topics is based on this concept, and I'm sure all of you are getting ready for our ACE conference in Bhubaneswar. Very soon we will come out with our scientific program, and the foreign faculty, the Indian faculty who are going to be participating and presenting and who are going to enrich our embryological knowledge. So with that, without wasting much time, let us start this journal club. And over to you, Dr. Manisha.
Thank you so much, ma'am. Your tone always set the stage so perfect. Our first speaker of this evening is someone who wears many hats: eminent scientist, mentor to many, educator, and a true and fierce voice in the reason of ART practice. Our past president, Dr. Priya Kannan. Dr. Priya Kannan, at present working as a director and embryologist at Garbha Rakshambikami Fertility Center, Chennai and Trichy. She has many accolades and awards to her credit. She has authored many chapters. She is secretary of Tamil Nadu chapter of IFS, secretary of IMA Chennai, Chennai district coordinator of IMA. She has been co-investigator of two prestigious research projects. And we are actually keen to hear her. And today she'll be presenting on evaluating the impact of single embryo transfer on live birth rate and multiple pregnancies, insights from the recent guidelines and studies. We look forward to learning from your vast experience, Dr. Priya. The screen is all yours.
Thank you, Manisha. Thank you for inviting me. Thank you, ACE, for inviting me. I'm just going to start sharing my slide. Yes. Okay. So with that, I would like to, just a second, it's just. Okay. This, yeah. Okay. My topic given to me today is the impact of a single embryo transfer on live birth rate and multiple pregnancies, insights from guidelines and studies. Now, we all have seen this. It's been around for quite some time. The guidance on the limits to the number of embryos to transfer, a committee opinion from ASRM. And as we know, it has been evolving. I'm sure we all remember what was given 10 years ago, what was given in 2017. This was the one in 2021. And they had segregated based on maternal age and also on the staging of the embryo and also on the euploid status of the embryo, whether the embryo is favorable or not. In this, as we can see, if it is a euploid embryo in all age groups, whether it's cleavage or blastocyst, the recommendation is to transfer a single embryo. Whether it is favorable, if it is maternal age is less than 37, still one embryo. And only after that, it's been the number of embryos that is recommended for transfer increases. We recently had this publication as well from ESHRE on the number of embryos for transfer in IVF and ICSI. And it has many sections to it. That is from part A to F on consequences and risk of multiple pregnancy starts with that. And then social, legislative, economic factors, various clinical criteria, that is various clinical scenario in which we would have a doubt or whether to go in for a double embryo transfer or a single embryo transfer. Various embryological situations where we will also have a doubt whether to go for single embryo transfer or a double embryo transfer, and various other strategies for embryo transfer. And they also have talked about patient counseling on embryo transfer. In all of these chapters, one thing that is in the clinical scenario and in the embryological scenario, what it's very clear is that they have always wanted to err on the right side of the risk, which means they want to take less risk, even if it means a little bit lesser acceptable or lesser pregnancy rates. So they want to keep the mother and the child safe. And that has been the criteria in this particular guideline. Now, the question arises, why are we talking so much about whether to transfer a single embryo or a double embryo during an embryo transfer? As we have known that a double embryo transfer has got an increase in success rate. However, it is also associated with higher multiple pregnancy rates. Now, why are multiple pregnancy rates in talk? Because it increases the risk of obstetric and neonatal complications such as miscarriage, preeclampsia, prematurity or birth for the child, low birth weight for the child, and perinatal mortality as well. I am sure all of you have heard about this particular scenario case right now, which happened just now about 10 days ago in Pune, where a mother who has had, who unfortunately did not survive her delivery. While the media goes on and on about the money and all that stuff and everything, let's just talk about the science here. This was one patient who was treated for ovarian cancer, but went ahead and had a pregnancy through IVF. And that is why we are interested, through IVF using donor oocytes, and she had twins. And by 27, 28 weeks, around 7th, 8th month, she had probably, it was not very clear from the news, but then I assume that she probably had a preterm labor, probably also because of high BP, which means that she has to be delivered, and she had twins. And she had twins, unfortunately, because it was about 7th, 8th month or so, then the babies need NICU care, which of course is a prolonged NICU care when you're delivering at 28 weeks to 30 weeks. And unfortunately, 2 to 3 hours after the delivery, she had multi-organ failure and she did not survive. Very unfortunate. But then here the take home is, we are looking at an IVF involved and twins here, and the mother has not survived. That's something we always have to have in mind before we do an intervention. Safety above intervention. Now, with this background, because it is fresh on our mind, I thought I will just state that as one of the example. Now, why do we always correlate multiple pregnancy rate with our single embryo transfers? In a population study, with a large population-based study in ART conceived infants, when they had seen an increase in proportion of single embryo transfers from 5% to 64% starting from 2000 to 2017, which was also associated with decreased multiple pregnancy rates from 53% to 26%, and a simultaneously steady decrease in preterm birth and low birth weight babies. Well, we had the Cochrane published on similar, on what about the pregnancy rates in comparing single embryo transfers to double embryo transfers in 2020. And this was their conclusion. They concluded that the chance of live birth was reduced in women undergoing single embryo transfers compared with double embryo transfers. But when we look at that statement, I would like to translate a little bit of that Cochrane into plain English for us. So which means they looked at two particular scenarios in all the trials they had looked at. One was a repeated single embryo transfer of 2 attempts compared to a single double embryo transfer. Here, their live birth rate was about 34 to 46% in the repeated SET, that is cumulative pregnancy rate. In a single DET, their pregnancy rate was about 42%, which, of course, very less multiple pregnancy rates in the single embryo transfer group compared to the double embryo transfer group. They also had looked at another scenario, which is what probably led to that conclusion, comparing one single embryo transfer using a single embryo, another single embryo transfer using 2 embryos. Here, the clinical pregnancy rate was also low. Live birth rate was also low, which is about 27 to 35% in the SET compared to 46% in the DET. Of course, with very less multiple pregnancy rates in the single embryo transfer group. That was in 2020. We are in 2025. So I thought I would look at another large study, which would guide us on if there has been any improvement because of various factors. Of course, 20 to 24, I think we forget that we had any work to do. But after that, we started our work. So in 2022, we had this publication again, which was a large study, which had about 85 studies, of which 14 were RCTs and 71 observational study. This study also compared DET and SCT, and they also concluded that SCT decreased the probability of a live birth rate and lowered the rate of multiple pregnancies. The differences of live birth rate and the multiple pregnancy rates between the SCT and DET groups became insignificant when the patient's or the female partner age was more than 40. In the group which had SCT, it was associated with lower risk of poor outcomes than those compared with the group which had double embryo transfers. The poor outcomes which were compared and found to be less were cesarean sections, antepartum hemorrhage, that is bleeding during pregnancy in the later stages due to separation of placenta, preterm birth, low birth weight, Apgar less than 7 in the newborns, and the need for neonatal intensive care admissions in the newborn. They also had subgroup analysis according to embryo stage, whether it was a cleavage or a blastocyst transfer, or the type of transfer in terms whether it was a fresh or a frozen transfer. Still, they concluded that the chance of live birth in a DET was significantly greater than in the SCT groups in all the subgroups. And they compared, and they also did a subgroup analysis using good quality embryos and poor quality embryos. So they compared transfer of 2 good quality embryos and a single good quality embryos. When compared in this group, there was a lower possibility of multiple pregnancy by transferring a single good quality embryo, but it also had a lower live birth rate. And when they compared groups with the poor quality embryos, the chance of live birth after transferring a single poor quality embryo was about 57% of that achieved by transferring 2 poor quality embryos. Of course, and there was no statistically significant difference of multiple pregnancy rates between these 2 groups. And hence they said, probably they concluded that probably if you have poor quality embryos, we might better off transfer 2 poor quality embryos rather than 1, because you have negligent or no statistical difference of multiple pregnancy rates, whereas the live birth rate will be acceptable in the acceptable range. In multiple pregnancy rate, in regards to that, of course, in all the papers that we have gone through, and even in this particular RCT meta-analysis, the single embryo transfer group did have a significantly lower multiple pregnancy rates than in DET. While it was about 16.7% in the DET group, it was about 0.7 to 1% in the single embryo transfer group. However, we just have to bear in mind their subgroup analysis also showed that this difference of multiple pregnancy rate was significant only when the female partner age was less than 40. Above 40, there was no significant difference in the multiple pregnancy rate in between these two groups. As a correlation, clinical pregnancy rate was also lower in women less than 40 years in the single embryo transfer group, whereas in the double embryo, whereas when women where female partner age was more than 40 and in frozen cycles, they did not find a difference. In terms of maternal perinatal outcomes, the single embryo transfer group definitely had a lower risk of cesarean section, preterm birth, low birth weight, antepartum hemorrhage, APGAR less than 7, and NICU admission rates. But they did not find any difference in miscarriage rates, gestational diabetes, preeclampsia, perinatal mortality, or birth defects. In terms of correlation to maternal age, as I have already told you, in less than 40 years, the single embryo transfer did have a lower clinical pregnancy rate and live birth rate, and a lower and much lower multiple pregnancy rates. Whereas when the female partner's age was more than 40, the difference in live birth, clinical pregnancy and live birth and the multiple pregnancy rates was not very significant. Of course, we always come back to this. We do not want to jeopardize our live birth rate or clinical pregnancy rate because that's the first step that we want to see in our patients. But we always have to keep in mind the safety of the procedure that we are doing in terms for the mother and the baby. And hence, we have to find a via media of where we can have adequate success rates and also not pose a risk to the life of the mother or the child. Just putting in perspective a little bit about how embryo transfer has evolved. We used to do multiple embryo transfers, then came around the double embryo transfers, and now it is a single embryo transfers. The historical switch from multiple embryo transfers to two embryo transfers, it did bring about a significant reduction in the multiple pregnancies without a much loss of pregnancy potential. However, whenever we are doing the next step, which is going to single embryo transfers, we also have to, though it does reduce the twinning risk to a large extent, we also have to keep in mind the expense, the declining pregnancy rate, the need for probably more than one treatment cycle, a potential delay in the treatment success, and potentially delay and higher treatment costs. So this is something I thought I inferred from what these papers have told. In women less than 40, and when there is a good quality embryo available or a euploid embryo available, as ASRM has mentioned, single embryo transfer should be incorporated into our clinical practice owing to the significant reduction in the multiple pregnancies and definitely an acceptable live birth rate. In the absence of good quality embryos, double embryo transfer may be a preferable option. And in women more than 40, the current evidence is not sufficient to recommend any appropriate number of embryos for transfer. Having said this, I would like to bring in our own ART law into the picture. It says 2 embryos at 1 is always preferred, 2 at the max for at any general given point of time, 3 only in special conditions, such as whatever the special conditions we want to mention and make sense of it, that's when it is allowed. More than 3 is not allowed in India. And hence, though ASRM says more than 4 or more than equal to 4, in India, it's 2, maximum 3, and that's about it. Thank you very much for this opportunity. And I'd be very happy to take any questions whenever the moderator gives us time. Thank you so much.
Hello. Hello.
Gaurav, we can hear you.
I think it is Dr. Sanjeev.
Oh, hi. Hello.
Yeah. Hello, Priya. Excellent talk. This is
Thank you, sir.
Dr. Sanjeev Kut from Pune.
Hello, sir.
No, excellent talk as always, and the learning just continues. So we get the message absolutely right. No, I just wanted to add a rider to that Pune case which you mentioned. That patient had placenta previa, central placenta previa.
That's right. Central
And
placenta.
that's the reason. See, that's the reason of that massive hemorrhage and
Massive hemorrhage,
probably
yes.
loss. That's right. No, that's the only small thing I just wanted to.
Thank you.
Thank
Thank
you,
you for that
thank you.
additional information.
Thank
I couldn't get much.
Okay.
Dr. Manisha?
Yeah,
Yeah,
yes.
yeah.
Ah, so now we are moving to our second speaker. It gives me a great pleasure to invite someone who needs no introduction in our ACE fraternity, our Vice President, Dr. Gaurav Majumdar, who is a pioneer in single embryo transfer strategies in India and a molecular diagnostic part as well in ART lab. He'll be talking on topic on optimizing single embryo transfer strategy for maximizing success rate. Dr. Gaurav, we're truly looking forward to your insight. Over to you.
Yeah, thank you. Wait, can you see my screen?
Yeah. I have stopped sharing my screen. Oh, sorry.
Have you stopped sharing?
Yes. Now you can.
Okay, so this is probably not yet visible.
It is visible. Just make it slide.
Okay.
They can see your slides.
Yeah.
Yes, we can.
Yeah. So thank you, Manisha, and congratulations to ACE for again a good engaging session on single embryo transfer. And it was great to get all the info from you, Priya, about the ASRM guidelines. And now probably you can just evaluate that same data which has been published against real life data from our center in India, who's doing mainly single embryo transfers. And then it was really interesting to hear all, because I had not read the last paper, the last recommendation of 2025, right? That was 2025. The ASRM.
ESHRE or the ASRM was 2021. The last
Okay.
one is 2021. The ESHRE is 2023.
Okay. So it'll be interesting, Priya. Once you take a look at our data, then it'll be interesting to analyze few aspects of why we are seeing certain trends and of the concordance also between what we saw and what has been published by the SRM and the ESHRE. So I will just give you that, and then perhaps a few tips about what we can do to get there. So like you said, that the number one goal of IVF is having a healthy baby, right? Everybody wants a healthy baby, but at the same time, okay, why is it not going forward?
We can't see your slides.
You can't see my slides?
No, I'm not.
I can see
There's
your
only
slide,
the
but it's
first
not
title
moving.
slide.
Yeah, it's not the title slide.
You can stop sharing and share again.
All right. Let me start again.
Now they are visible. Thank you, Dr. Gaurav. Yeah.
Right.
Yes, it's
So,
moving.
so,
Very
so in
visible.
addition to a safe pregnancy, a normal pregnancy, such are the market pressures that we also would like to have the higher the better in terms of success rates, right? And so what we resort to is this, where most centers, they tend to transfer multiple embryos in the hope to boost their pregnancy chances. But unfortunately, when multiple embryos are transferred, then almost 30 to 40% of the resulting pregnancies are in the form of twins and triplets. And while we are all Indians and we always like a bargain, and it would be great to get two for the price of one, or just complete our family in one shot. What we did not bargain for were all these complications that Priya has also already mentioned that are associated with these twins and triplets, be it for the mothers in the form of preeclampsia, diabetes, excessive nausea or vomiting during pregnancy, then preterm labor, or for the babies where there's an increased risk of stillbirth or premature birth, low birth weight, and heightened likelihood of cerebral palsy, infant mortality, admission to nursery. So I'll give you our complication rate also. So we have to make a choice, either between a higher pregnancy rate and or thinking about safety in a single pregnancy. And sometimes this is a non-negotiable choice, right? Everyone would like a higher pregnancy rate. And now that Priya has categorically shown that a single embryo transfer has been shown to result in slightly lower clinical pregnancy rate as well as live birth rate as compared to a double embryo transfer. And so it's the number of embryos, right? And why this is one of the primary reasons that most clinicians have not been very excited about adopting elective single embryo transfer because they believe, and there are papers which say that one embryo results in lower pregnancy rates. So this is one major concern. Then also, for some embryologists, maybe selecting a single embryo becomes a difficult task. And now with the era of, freeze-all, it also means that you'll probably have to get your vitrification absolutely spot on, because transferring single embryos would mean freezing single embryos, and that too with 100% survival. On the side of the patients, the clinicians, would argue that patients prefer twins. So, everyone who comes in, they want twins in India. So that's why we cannot do elective SET. Well, that is just a result of a lack of knowledge about the risks and complications associated with multiple pregnancies, and that can be easily solved by adequate counseling. Probably another fear is a risk of treatment dropout after embryo transfer failure. So everyone tries to, get the maximum out of every opportunity. And that can be done by transferring multiple embryos. So we heard from Priya, right? So we analyzed our data, and I had done so before, for 2019-20. And now, since we finished in December, we finished the entire, follow-up of live birth for 2023, because the last embryo transfer in December 23, it yielded a live birth in November 24. So, but since then it's already been 4-5 months, but that's when we compiled the entire data for 2023. And this is what we saw. So then I'll try to put this in relation to what Priya already showed us. And I'd like to see what are the primary differences between our results and what has been published. So let's directly go to, so you can see this is all about day 3 SET, day 3 DETs, day 5 SETs, which were the maximum 542 transfers. Then day 5 DETs, which were only 52 in number. So 10% of the total SETs of day 5. Then 247 day 6 SETs versus 36 DETs for day 6 embryos. There were in total about 1,000 FETs for the year 2023. Now you see that the live birth rate after transferring single day 5 blastocysts was 46%, right? Which is very high. You cannot ask for a live birth rate probably higher than this per single embryo transfer. When we transferred two day 5 embryos, which was in very few cases, only 52 cases, we had a live birth rate which was 49%. So it was higher, but it was not statistically significant. Even for the beta HCG, it jumped from 60 to about 65%. So not a big difference. Now, if we look at the day 6 embryo data, you see a appreciable drop in the live birth rate as compared to day 5. Day 5 was 46 and day 6 is, significantly lower to about 28%. And when we transferred two day 6 embryos, then it jumped up a fair bit. 5 percentage points is big. Now, what it did to the multiple live birth data is interesting. That obviously with single day 5 embryos, I will not talk about day 3 embryos right now because predominantly 90% of our transfers were at blastocyst stage. There was only 3 monozygotic twinnings in these 500 cases. But there was in the DETs, there was about 33%, even though the numbers were very small, but it resulted in 33% of twinning. And similarly, for day 6 with single embryo transfers, we saw only 1% of monozygotic twinning with one embryo. But the moment we transferred two day 6 embryos, it went up to 27%. So this is the result. Now, if you look at the early pregnancy loss at the bottom, it's more or less same, but only for day 6 DT. Now, let me tell you when we transfer two embryos. So ideally, we are a center who probably for the last 8 or 9 years only does single embryo transfer. And we transfer DET only in poor prognosis cases. So what Priya mentioned was for poor quality embryos. So these are not really poor quality embryos, but these are patients where they've had 2 or 3 failures and now they're desperate and frustrated. And so then we say, okay, let's transfer 2 embryos to see if it helps, right? Or the morphology of the blastocyst is poorer. So these are embryos which are say like 5 BC or 5 CB or 5 AC or CA. So there, say for day 6 embryos, we definitely we would consider transferring 2 embryos. So that is why we see not such a huge jump in live birth rate with SET versus DET. Whereas Priya, you showed clearly that DET resulted in a higher pregnancy rate and a higher live birth rate. So I was just thinking that we did not see that because this DET, these were not patients where two top quality blastocysts were transferred together. Probably none. Only top quality embryos were transferred in cases where they had 2 or 3 previous failures with single embryo transfers. So this was the major difference. And again, with we believe that with day 6 embryos, where we see a much bigger drop in implantation rate versus day 5 embryos, you see the implantation rate for day 5 embryos per single embryo was close to 60%, right? Whereas for day 6 blastocysts, it is only 40%. So almost 18% drop of implantation potential from day 5 to day 6. So here, probably it makes sense to transfer 2 embryos, right? So, okay, these were the babies that were born. So at the end of the year, we saw a total of 337 singleton births, resulting in 337 babies, whereas there were 23 pregnancies with twins, which resulted in 46 babies that were born out of these 23 twin births. So the mean birth rate for the singleton pregnancies was 2.2887 grams, whereas for twins it was 2,120 grams for these 46 babies. And the mean gestational age here was 38 weeks, whereas here it was 35 weeks. And we saw only 10% of these singleton babies being born before 37 weeks, whereas 87% of these 46 babies were born before 37 weeks. And some of them were also very preterm, which is before 32 weeks. So accordingly, a lot of these twins, they underwent nursery care also. Not lot, but significant proportion. Whereas here there were much fewer patients who underwent nursery care. Now one could argue that in India it's still feasible to have twins, right? As opposed to having twins in the West, where it is prohibitively expensive, the nursery care, and if there's a complication, then the cost just goes up through the roof. Whereas in India, probably that is not the case. But we have clinicians on the panel who can discuss this. I don't know much about it. I'm an embryologist. So this is some food for thought for everyone. And this is again just basic info that why our implantation rates were so high was because we were transferring single embryos. So when one embryo is transferred, and if it implants, it gives you a implantation rate of 100%. Whereas if you transfer 2 or 3 embryos, then it just gets divided. Even in case of a pregnancy, the implantation rate gets divided. So obviously, if you start transferring embryos individually, then the implantation rate really shoots up. But that tells you the real potential of an embryo, which is generated in your IVF laboratory. So it's a great distinguishing factor to assess the quality of a laboratory, which you really cannot do when you're transferring 2 or 3 embryos. So for so many years, we transferred multiple embryos in the beginning. And I used to wonder why our implantation rates are not going beyond 20% or 25%, whereas all the papers that we would read from Europe and America would say 40%, 50%, 60%. And so that was the reason. Then embryo selection in ESET is vital. And again, single embryo transfer helps you understand that which embryos actually will give you the highest chance, right? And so in that case, once you know, after you have to generate data, huge amounts of data, right? But then as a proof, you have that data in front of you, that what is the chance of a 5AA coming out of your lab, what implantation potential that has vis-a-vis a 5CA or a BC or a CB. And then you can make informed decisions about transferring double embryo transfers for cases where you expect a much lower implantation potential. So then you can make an informed choice, right? So this is again all data where we segregated according to embryo quality, and we actually saw that our implantation rate, it reduced with reducing embryo quality. So this was proof for us, both for day 5 and day 6, and which then helps us choose cases where we should transfer only one embryo versus cases where we can actually advise the patient that going in for a DET would probably help their cause more than going in for a single embryo transfer. But having said that, we still somehow we end up 90% of our transfers across the year for so many years have been single embryo transfers, because we are firm believers. Again, the first slide that Priya showed, that 2 single embryo transfers sequentially will result in a cumulative rate which is equivalent, which is higher or equivalent to a single DET. But what the benefit that you have there is completely eliminating the risk of twin pregnancies. And Dr. Shweta is here. She's a clinician at Gangaram, and she will tell you why, if I were to tell her that for say a couple of months our live birth rate is going down, right? We all see these variations in the IVF lab. And I tell her that, do you really want to, because things are not going okay with the laboratories, so probably should we start transferring 2 embryos? And she's like, hell no, right? So vitrification, again, it's possible to get more than 95% vitrification with single embryos. So vitrifying single embryos poses almost no risk of cycle cancellation. If you don't believe me, then you should just remember our data and know that it works. And so we strongly believe that vitrify only the number of embryos that you want to transfer and not 6 or 8 embryos, which we see every day. Reports from centers where they have frozen a huge number of embryos and then they thaw them and culture them, or do things which are inexplicable. And then they say that the embryo quality is not good, and we are discarding embryos. So that should not be the case. And remember that vitrification of poor quality day 3 embryos leads to very poor survival rates. And again, patient preference of twins is only because of lack of knowledge and can be solved in 1 second with counseling. The moment you tell them that these are the risks, especially all women above 40, where they come in saying that, oh, I have only one chance, and this is my only chance to have 2 babies to complete my family. And almost 70% of women above 40 going in for donor recipient cycles, they come and make a proper demand for 2 embryos to be transferred. And that's the time when you have to clamp down and you say, no ways, right? That is your responsibility as a fertility clinic to say no. You have to say, no, you cannot do that. We cannot transfer 2 embryos because of A, B, C, D, so many risks, right? And so it works. And the only prerequisite for elective single embryo transfer is to have a good IVF lab, right? And where you can document high clinical pregnancy rates, high live birth rates, because we again firmly believe that more transfers per retrieval is the key to having higher cumulative success rates. Uh, uh, Transferring more embryos at one go does not help. What helps in our experience is multiple transfers. The moment you give a patient a chance of multiple transfers per retrieval, then her chances of taking back home a baby become really high, right? So we are firm believers in that. And so if we have 2 blastocysts, then hell can break loose, but we will not transfer those 2 together, but we will transfer them in 2 FETs, right? So that's our mantra. And so it's a gradual process. And I was having a chat with Dr. Shweta, and she had great insights about how to choose patients initially where single embryo transfer is absolutely a necessity, and which can be a great guide for people to start, choosing patients. So requires physician and staff education, patient education. Then you have to improve your embryo culture and you have to improve embryo selection. These are non-negotiable. We are in a we are talking of AI selection and we are talking of so much advancement, but still we are doing the same thing which we used to do 40 years back, which is blindly transferring 2 or 3 embryos just because we don't want to take the onus of of a failure. So you have to do, and this should be linked with enormous amounts of data analysis. Otherwise, you will never be able to, assure confidence to the clinician that this is what is happening when you're transferring, whatever you are. And these are our trends from 2015, where which shows that this was a slow process where initially we were doing 30% of transfers were single day 5. Then it went up in 16 to 60%, then 2017 to 60%, then slowly, gradually, we kept increasing and we kept reducing the DETs. From 2017 onwards, we have never transferred 3 embryos in our center, and which is this blue colored here. And now we have reached a stage where we are routinely transferring. Almost 80% of all our transfers are single embryo transfers, and about 10% of them are still, we are transferring 2 day 3 and 2 day 5, 2 blastocysts. As a result, our implantation rates have gradually increased and our multiple pregnancy rates have really gone down to almost less than 5% for the whole year. And we are very proud of that achievement. And so this is all that Priya told us, that for younger patients, ESET should be considered. And if you have more than one top quality embryo for transfer, then definitely a single blastocyst transfer is advised. Then all first or second cycles, you can transfer single embryo transfers. Then recipients of embryos from donor recipient cycles, surrogacy cycles, PGTM cycles, these are all cases where only embryos should be transferred individually in single numbers and electively. So that was about it. That's the conclusion. Don't transfer more embryos. And multiple pregnancy rates. Another thing that you can take home is multiple pregnancy rates are still low when only 2 embryos are transferred. So anybody who's still transferring 3 embryos, you can at least take some heart from this data that at least come down to 2 embryos, if not 1. So, but with 2 embryos also, you saw that we had a multiple pregnancy rate of close to 30%. But those were poor embryos, poor prognosis patients. And transferring more embryos can never compensate for poor embryo quality or a poor laboratory. So, rather than increasing the number of embryos, try to focus on improving your culture conditions, right? And that's gonna help in the long run. And elective SET, again, I'd like to underline this fact, gives you a chance to perform multiple FETs, therefore resulting in a higher cumulative pregnancy rate. So thank you very much for your attention, and let's hope for a more fruitful discussion in the next session.
Thank you, Dr. Gaurav. That was truly enriching. And now we are moving towards our much awaited open house discussion, where we'll explore the practical application and clinical realities of elective single embryo transfer. We are fortunate to be joined by the powerhouses of experience and clinical brilliance. Dr. Shreyas Padgaonkar sir is there, Dr. Shweta Mittal ma'am is there, along with Dr. Priya and Dr. Gaurav with us. Actually, no matter how well we optimize lab practice, we always believe that no matter how well we optimize our lab practice, the success and the appropriateness of ultimately depend on clinical judgment, the ability to balance science with sensitivity. Our clinicians are the ones who translate science into real decisions, real outcomes, and real lives. Their perspective make this decision complete. A brilliant. So we are fortunate to have with us. My screen is not visible. Okay, let me share my screen. I'm so sorry. So we have 2 brilliant clinicians with us. Dr. Shreyas Padgaonkar sir, who is an eminent clinician as well as great embryologist. He has done his MD from University of Mumbai in 1992, done his fellowship in reproductive biology from Royal Women's Hospital, Melbourne in 92-93. He has restricted his practice into fertility only since 1994. He has been chairman to accreditation committee, SAR, Secretary General of Indian Society of Assisted Reproduction, founder member and executive committee member of Fertility Preservation Society India, patron member of PCS Society India, and he has helped establishing almost 16 IVF clinic in India and abroad. Along with that, we have Dr. Shweta Mittal with us. He's an eminent name in our field. She is co-director and unit head at Center of IVF and Human Reproduction at Sir Ganga Ram Hospital, New Delhi. She is Secretary General of Indian Fertility Society and treasurer of IFES. She is very well-known name and in the field of reproductive medicine and embryology as well. So without taking much time, I'm inviting both of you. We welcome you on behalf of ACE fraternity, and we have our own. We are fortunate to have Dr. Sujatha ma'am with us to moderate this session. Dr. Sujatha ma'am is again known for her clinical lab excellence and clinical acumen, along with the inspirational leadership. So over to you, ma'am.
Thank you very much, Manisha. First, at the outset, I would like to congratulate both Priya and Gaurav for this excellent presentation. And welcome, Dr. Shreyas and Dr. Shweta. And congratulations, Dr. Shweta. Recently, I saw a post on some recognition you have received from your hospital. Congratulations on that. Okay, so now I think before I start, I just would like to comment something lightly on Gaurav's presentation. So Gaurav, one of the prerequisite for single embryo transfer is to have a clinician who says it is okay to have a lower live birth rate, but still do single embryo transfer. But the thing is, all of us are under so much pressure. The moment the pregnancy rate dropped by 1 or 2% from the previous month, and that's it, hell breaks loose. And we are all just scrambling to find what was the problem. Anyway, so now, Gaurav, the first question to you from your presentation, was a age segregation done? How many of these patients in that single embryo group were lesser than 35 years and how many were over 35 years? Have you done an analysis on that? Because age is an important criteria, right, for the success of embryo transfer?
Yeah. We did a age analysis. I've not put those slides there, but yeah, to let you know, we pretty much we go by embryo quality. So if we have good quality blastocysts, then we definitely, and that's how, in about 1,000 transfers, we end up doing about 800 single embryo transfers. That's because we, irrespective of age, we go with single embryo transfers. And at least, say, if we were to transfer for a patient more than 40 years, then if we have 2 blastocysts, we would still give them 2 FETs. But in case if they had 3 blastocysts, then we'd club them in a way that we give them a single SET followed with a DET. But again, there the clinician is the one who decides whether the patient of advanced age is fit to undergo a DET. So they make that decision based on the fact whether the patient is diabetic or she has, is hypertensive and with her past history. So there are a lot of advanced stage patients where, irrespective of embryos, the clinician says that they will only go through SETs.
Okay, so, see, and all these single embryo transfers which you have presented here, they're all elective single embryo transfer, right? Like you have not included the embryo transfers where that single embryo is the only embryo which is available for transfer.
Yeah, obviously. I mean, there will be a very small portion of those patients because majority, this is the whole year's data. So these are majority are very good prognosis patients where they had multiple embryos, but we still chose to transfer only 1 embryo.
Okay, so Dr. Priya, I would like to ask for your experience here about age and the choice of single embryo transfer. What would you think? Because the literature, even the American ASRM very clearly says that in elderly patient, there is no recommendation of opting for single embryo transfer. And this is usually done in a good prognosis cases, younger patients. So what is your opinion on that and what is your practice? We all know that it is actually we need the single embryo transfer in elderly patient where the complications are much higher. But if it is not going to work there, what is that we have to do?
Actually, Sujatha, by what the statistics has said is that above the age of 40, I mean, if you are using own eggs, then probably then the live birth rate is not very optimal, and hence, because of the quality of the egg and the embryos, the multiple pregnancy rate is also not significant. So in that case, then it is clearly said that, I mean, the evidence shows that above the age of 40, if you transfer even double embryo transfer, I mean, I don't think we are transferring 4 and 5 as ASRM has said, but then I think 2 and 3 is something that 2 is something we can definitely do. Even if you do that, the multiple pregnancy rate is also very less in women above the age of 40 if you're using own eggs. However, if you're doing donor eggs, then I think we should shift to the criteria to single embryo transfer, because it is a favorable embryo and a good quality embryo.
Dr. Shreyas, what is your take on this opting for single embryo transfer in your practice?
Do you want to know what I do, or do
Yes.
you want?
Now, what you do, and then why is that you are doing that?
So, see, in a private practice, as everybody has been talking about in India, patients are in a rush to get pregnant. Many people have this distorted idea of, great life after having twins, everything happening in one go. So as a clinician, it is our responsibility to actually counsel, because that's, as Gaurav said, that's the key. And it's not really very difficult to convince them. And I think what happens is, why many clinicians don't do that is, I believe that how well you can convince a patient basically depends on how much you believe in that procedure. We can talk endlessly here, but if the clinician is not convinced himself, it just doesn't translate into a good counseling, across the table. You just can't convince somebody sitting across something you don't believe. So I think first important for the clinicians is to believe in their own lab and their own abilities, and only then we can kind of convince patients. I don't think it is very difficult to counsel patients and get them accept single embryo transfer. It's not very difficult.
Sir, can I say one thing? So that's great that the clinician has to believe in single embryo transfer,
Yes.
but the only person who can get a clinician to believe in single embryo transfer is the embryologist. The onus lies on the embryologist to show him the data, to give him the confidence. Because if the data doesn't speak, and if the lab is not very good, and if we are seeing a major dip in pregnancy rates with single embryo transfer, then no clinician in their right mind would opt for a single embryo transfer.
Yeah, Gaurav, but what happens is many clinicians don't give any chance to their embryologist to create any data from that angle. So at least what I would recommend is clinicians to start actually single embryo transfer for at least good prognosis patients to start with. Create some data in your lab, and then you can convince yourself, and the embryologist can then have a chance to convince you. And I think embryologists need to collect data to start with, a center who doesn't do a single patient of single embryo transfer. At least the embryologist should bring the data saying that, okay, this is the conversion rate into a blastocyst in my lab. So at least convince them that they can create good quality blastocysts, at least in terms of number. Then maybe they should take pictures of the blastocyst and try to convince the clinician, okay, this is what is called a good grade blastocyst, and this is not a good grade blastocyst.
No, and a direct measure of that is the implantation rate. So the
but many times they are not even given a chance to achieve that, So
no, sir, as a clinician, it is your duty to know that
yes.
Your laboratory, what is the output of your laboratory?
Yes.
Right?
Yes, of course. And actually, I always encourage clinicians to sit in the lab. Nowadays it's impossible for the new clinicians to actually learn something of him. We were forced because we didn't have a choice. But I actually recommend young clinicians to go and sit and spend time in the lab, sit behind the embryologist and actually look at the monitors, see the blastocysts themselves. Maybe that will help them understand this whole process and get convinced about single embryo earlier.
So, Dr. Shweta, see, in your data, I just saw there not much difference between the single embryo transfer and the double embryo transfer outcome. But that is not the case what we see in the literature. It is significantly, the pregnancy rate is significantly higher with double embryo transfer. And even I was just sitting through one of the review calls this morning in one of our centers, and I noticed that there is almost close to 20% difference between single embryo transfer and double embryo transfer. So what is that which actually gives you such good pregnancy rate? I know the laboratory things we can't change much. Is it the choice of patients?
So, I will just bring forth both the answers to the first conversation, because we have already seen the data of our lab, and you have heard, very senior embryologist Gaurav and very senior clinician Dr. Shreyash, and embryologist. But how did we reach that stage was, did you see the slow transition? So it was the chief embryologist who started this idea. I can definitely vouch for that. But it is always the senior clinicians who have to get convinced and adopt it. Then slowly it was happening. If you could see, it was 30% single embryo. The implantations was decent. We went to 40%. And the clinicians were not even realizing that slowly all the embryos which were being frozen, and we are so much in sync right now that we cannot imagine, if I see two embryos like 5AA, even a 5AB, two together, it will surprise me. Now, the moment the senior clinician adopts it, then the next clinicians in the same unit, they start practicing the same. Then the next junior embryologist. So it's the whole team which follows the same pattern, and this pattern then becomes a norm. So that is the answer to go about it. And definitely the whole data keeping responsibility and the owners and this big herculean task has been taken over by the embryology team, who gives us this audit. If you can even do a quarterly audit and then an annual audit, you will reach this stage. The second question was that, which when I was listening to Dr. Priya's presentation and then Gaurav's presentation, then it's a fact that when we have two high quality embryos, they are never frozen together. So we are basically in our data comparing one top quality embryo. The second single embryo transfer is also a top quality embryo. It's not clubbed together. And we are then looking at two embryos transferred in a very small segment of patient, where the second one must have been more inferior as compared to the single, and that is why there was not much
Or
of,
both are inferior, or
or
both
both are
are.
inferior. Yeah, both could be average, or one could be like a BC. I know this. These are the typical grading where a second is added. Now, the data what Dr. Priya showed was a single embryo transfer, and I think outcome comparing a single embryo versus two embryos of the same quality. And the second data what she presented was a cumulative live birth rate, which was the same, almost the same. So this is exactly the difference in the two datas. So
The
when we
reason
realized clinically a few years back when Gaurav presented that data, that see, this is the live birth we are having. And I'm telling you, as a clinician, my OPD works like any other normal pregnancy, what I'm seeing. I withdraw all my hormones after 10 weeks, maximum 11 weeks. I just put them on iron, calcium. The amount of monitoring, I changed my clinic. I'm telling you practical tips. I came to one area where the ultrasonologist was only seeing twins and triplets from other centers. And one day after 3 years, she says, I have hardly seen twins in your practice, and I see the difference. So the difference will come. We need to take that plunge, and that can only come when the lab quality and your blastulation rate is excellent. Because see, few norms what we have made: previous live birth, any Mullerian anomaly, biconjugate, uniconjugate, previous mid-trimester losses, previous history of fetal reductions and patients losing pregnancies, previous preterm births, 26-week losses, any previous LSES, previous myomectomies and uterine interventions, and adenomyosis. We will just not even dream of putting two embryos. So, these SOPs, unless unless you are in sync with the embryology team, and unless the embryology team comes up with the data, give the liberty both ways. you know Show the clinicians what is the result, let the clinicians show embryologists, so all our data is accessible and all the consultants work in sync, then we can reach this stage.
Now, Dr. Shweta, my question is, have you ever got disheartened by the outcome of single embryo transfer?
There are many couple of occasions. It's not easy. The first counseling, it takes, believe me, extra 5 or 10 minutes. But when this counseling is reinforced by the embryology team when they visit the IVF lab, is a game changer, because it takes out a lot of load of counseling from the clinicians, because now the embryologists have stepped in. They are telling the same thing what initially the clinician had said. There are disappointing situations, but after one failed embryo transfer, my counseling is that there is a 50, 55, or maybe 60% chance of implantation as per the age. If you ask me what is the extra intervention I'm going to do, I say nothing. I'm just going to grossly look at, was your endometrium okay? I have not missed any hydrosalpinx. Are there any large fibroids? I mean, the gross check. If everything is in sync, I'm going ahead with another embryo transfer. So I think it's a constant counseling. And then when people see pregnant women sitting outside your OPD, they are convinced that this lab is giving the pregnancy rates. So I think it works, and it is working well for us. It is working very well for us.
So
Uh,
I
Dr.
come to
Sujatha,
Gaurav for
Dr. Sujatha, when you said that if we were to transfer two embryos, because you said that there was a 20% difference, and I fully agree with that. So I also sometimes think that right now we are settling for say a 50% clinical pregnancy rate with one embryo. And sometimes I wonder that, if we start transferring two embryos, we could probably go much higher up. We could go to 60, 65, even 70, right? And
yes.
I completely agree with you. But then I have asked my clinicians, I've told them this, that right now we are electively transferring one embryo, and so we are settling at 50%. If you want, we can start transferring two, because then you will hear those numbers of 70, 65, 70, 75. But then be ready for a OPD full of twins and triplets. So just say no. What we are doing, we continue to do that. So
Because, see, Gaurav, the reason why I asked was, as I told you, like just this morning, I was looking at some data. Okay, it's from the same lab where two CC grade embryos are transferred. Okay, both the embryos were CC. Okay, we have a 60% pregnancy rate. Okay, but where a single C grade embryo is transferred. It could be because of so many reasons. We still have to kind of segregate it, PGT, this and that. The pregnancy rate is only around 30 to 40%.
yeah, true.
So, if there is a question, so does it mean that you can't transfer single embryo transfer, C grade embryo? No, because C grade embryo, two C grade embryos has given us 60% pregnancy. But then that,
And then you will choose that. You will choose that when you think that two poor embryos, it's okay to transfer them, because you know that with single embryo, the pregnancy rate will be majorly compromised, right? But with good prognosis patients, not do that.
so what kind of tips can you give to the embryologist in terms of embryo selection? When I say that, like I mean to ask, do you track the embryo right from the oocyte stage and then say it's a good PN with good alignment of micronuclei, and then a good day 3 embryo, and then, an embryo becoming blastocyst quickly compared to the others? So do you track it continuously,
No,
or is it just a single look on day 5?
no, we don't do a continuous tracking from the PN stage. We track the embryo from day 3 onwards. So as a routine, we segregate embryos on day 3. Before that, we do group culture.
Okay.
Everything is together. And on day 3, we segregate them into two groups for every patient. One is with good quality day 3 embryos with, all that 7 to 8 cell equal cells, no fragmentation. And the other group is poorer embryos with more fragmentation, unequal cells. And then we then track them till
Okay.
day 5, day 6. So we know that this blastocyst is out of A group, or this blastocyst is out of B group. Sometimes very poor embryos in B group, the blastulation rate is much lower in the B group, where unexpectedly you will see a blastocyst out of very poor day 3 embryos. But we have more confidence in so we label each blastocyst is labeled as 5AA A or 5AB B. or 5ACA, like we in our own nomenclature, we know what is the origin of that embryo. And that helps us to rank the embryos also for transfer.
Do you use embryo glue for transfer or any other?
No, not normally. Not
Because
normally,
the
only for
reason
RIF.
Okay, so the reason why I asked this is when we started to use embryo glue, we realized that it was helping us only in our single embryo transfers. Like it was not improving our double embryo transfer pregnancy rate, but where I said like our single embryo pregnancy rate is around in the range of 40 to 45%, there we found an increase. So do you don't do that, right?
No, we use only specifically for documented RIF patients, and we are doing a study. We are actually doing a proper randomized study. One of our fellows is doing it. And till now, and it's a very strict control population that we've chosen in defining RIF. So we don't see any improvement. We are getting similar results. So
One more question from the embryology side. Is there any change in the loading volume or, do you do any changes in your embryo transfer procedure or is it just the same for single?
Just the same.
Okay. And Dr. Shweta, like I was just looking at one of the articles which just said that, the major factors which are involved in determining success rate post-embryo transfer is, of course, the age of the patient. They had also mentioned about the number and as well as the stage of the embryos. But they had also looked at the operator in terms of the clinician who's doing the embryo transfer. Have you seen any difference?
So we have done this analysis a couple of times, and because in our center, more or less everyone is a senior, clinician. So when it came to operator-based pregnancy, change in pregnancy rate, we did not see absolutely, there was no change. But we also very critically analyzed our protocols of FET cycles because I think about 80% are FET cycles. And we concluded that our natural cycle, modified natural cycle, and very recently, even for ovulating women, letrozole, and whether they are induced with natural LH surge monitoring or with HCG, are giving great pregnancy rates, and we did not see any difference. I think, Gaurav, the pregnancy loss rate was little higher in our HRT-induced cycles as compared to others. So now what we are trying to shift is more and more to natural and modified natural in ovulating women. So that is the change we have made, but not operator based. We did not see because I think our consultants have a very large, volume of embryos being transferred.
Dr. Shreyas, would you want to add anything to this?
I won't be able to comment on operator-based differences because I don't work in the institute. But in today's world where everybody is doing a ultrasound guided transfer, and if a junior doctor is there, there is somebody always supervising, there should not be too much of a difference between doctors once they have reasonably good number of embryos transferred under their belt.
In fact, when our fellows do the embryo transfer, because we have a lot of fellows, because they are always been performed under the supervision of a consultant, how Dr. Shreyas said. So we haven't seen a change in the pregnancy rate when they have also done. But that was because they are under very strict supervision.
Okay.
And the slightest difficult embryo transfer is taken over by consultant.
Okay. And Gaurav, what is your opinion on hatching blastocyst? Does it give you the same kind of pregnancy like an expanded blast? Because I have heard many of the labs complaining that their success rates with hatching blastocyst is much lesser. Like sometimes even when the doctors, they get to know that this embryos has started to hatch, they say, oh no, this is not going to work. So do you have any comment on that?
So we routinely, before vitrification, we collapse the blastocyst, right? We follow a protocol where that's a routine in our lab. So we drill a hole into the zona and we collapse the blastocyst completely and then we vitrify it. So see, this becomes almost a automatic form of assisted hatching, right? Because then there is a hole. There's a gaping hole in the zona. So these embryos post-thaw, when we thaw them and we wait for 3 hours, we generally wait for 3 hours before we do a transfer, 50% of our embryos are hatching out because this herniation further, it facilitates hatching. And so 50% of our embryos are hatching out. So I can tell you one thing, that we also perform tons of transfers where the embryo has completely hatched out, because we are doing a majority of our embryos are day 6 blastocysts also. So it happens a lot of times that embryos completely hatch out. So there we have seen a slight drop in pregnancy rate with 100% hatched blastocysts. So this would be grade 6 in Gardner terms. But grade 5 embryos are actually our top performing embryos.
So do we have any questions from the audience? I think
there was just one question in the chat box, but that's related to number of embryos. I think the law is very recent and it's not going to change soon. In India, government has given a lot of liberty to the number of embryos. I think it is now the onus is on us, that how we have to optimize the pregnancy rate and reduce the number of embryos which are being transferred per patient or per ET cycle.
Ma'am, here I would like to ask one thing to Dr. Gaurav. Dr. Gaurav, as you are saying, you are doing, means we have seen your data in quite a many conferences that you are doing single embryo transfer. But what is the reason behind doing a group culture till day 3? Because we feel more confident when we are tracking our embryo. For single embryo transfer, we are noting down the PN numbers, then whether they were clover leaf. There are many papers of Thomas Ebner in which they have discussed the blastocysts which are looking absolutely perfect on day 5 are not able to give pregnancy. They are not grade 1 blastocysts as they are looking like. We are totally believing on morphometric data. So why are you doing this? Is it giving any better outcome? Co-culture is better in a way of blastulation or something?
Because we are transferring embryos at blastocyst.
Yeah.
So and even post day 3,
Right.
we are doing group culture only.
Okay.
Okay. So post day 3 also, we are grouping them into just 2 groups of good and bad.
Yes,
But
you.
still all the good embryos are together. So we are doing this because single embryo culture takes too much time.
Okay.
And there's a lot of exposure with group culture, and we work with large volumes. We
Right.
don't work with small volumes.
Right.
You can move really quickly
I
between
agree.
dishes, and we reduce the exposure time. So we have done the micro drop culture for also many years, but we realized it used to lead to a lot of exposure, enormous amount of time outside with one embryo, keep doing, making dishes was tedious.
Right.
So we just, this is just out of experience that we chose group culture.
Because at times we feel confused. Our embryo is having 20% or 10% fragmentation on day 3, but it turned out to be a very good blastocyst, 4AB, 4AA, 5A blastocyst on day 5. So you are going as per the grading of blastocyst. That is the final.
Small amount of fragmentation is actually good.
Okay.
And also we firmly believe that day 3 embryo morphology is a very poor predictor of blastocyst rate.
That's a very.
Because sometimes out of absolutely ridiculously bad looking embryos also that you would ideally you would just throw in the dustbin on day 3.
Yeah.
You get some blastocysts, which is very helpful. And sometimes with great looking day 3 embryos, you end up with zero, nothing.
Absolutely. So that's what I really wanted to hear, how to select whether we should be taking account of the theme morphology or not. Or so it was a
We do only to some extent, just to make a gross, segregation, but nothing more than that.
Thank you
Gaurav, earlier you would say, I mean, many years back, that trophectodermal grading you were depending on more, and then you changed and you said, no, now I feel that it's the inner cell mass.
Yeah. So we
And
get
that majorly determines your
we give much
freezing.
more importance to the inner cell mass now than the trophectoderm, and our data shows that.
And ma'am, Dr. Shweta ma'am was saying even in patient of endometriosis or adenomyosis, where we inadvertently getting poor quality of oocyte, you are going for a single embryo transfer because many a times we have seen very poor quality of embryos out of such oocytes. So,
See, Manisha, you know what? When
yeah,
we present this data and when we reach single embryos, so these single embryos were good quality embryos. Now, if consistently, suppose you have a cohort of patient, which
yeah,
Sujata had just asked, only one embryo, and that one embryo is a poor embryo, then that in itself will be bringing lower pregnancy rate. So basically, we do not really judge. So if suppose on the day of oocyte, there are very few oocyte defects which our embryology team says are major defects, and the rest of them they just ignore. And how he just said, Gaurav, that day 3 also he tells us, do not even discuss with me. Do not discuss your case before day 6. Do not inform your patients that there are, 8 day 3 embryos. Makes no sense at all. And the moment there is a blastocyst, conversion and grading that blastocyst, I think is what our lab totally depends upon. So
fantastic.
what we started with is immaterial and what we have landed up. And but of course there is an observation that a patient who's young, good prognosis, and makes 5 blastocysts will get pregnant in 1 or maximum 2 embryo transfers, and the rest of the embryos will be in tank for years together. And those who make embryos slowly will also get pregnant slowly. So these are the clinical, observations. Because we are not doing
Gaurav,
PGTA for all, but these are indirectly telling us the ploidy rates.
Right.
Gaurav, I have a question for you.
Yeah.
Um, now that you're doing a single embryo transfer, many labs are not so great at maybe even grading them. So nowadays we hear a lot about the new technologies coming into, usage of AI to select your embryos. Do you think that's going to change anything, or is going to give more confidence to the lab or the clinicians to for will it help in future?
I think there has to be a minimum criteria for application of AI to a laboratory. So there has to be a minimum criteria, because in laboratories which have poorer implantation rates and poorer pregnancy rates, there I don't think AI will be able to help. And we have had many instances um, where patients have gone through AI for euploidy assessment, and they have come back to us with previous failures, saying that the embryo was assessed to be euploid based on AI grading. And then we ended up with a miscarriage, and they found a trisomy in the POC.
Right.
No, no, of course, I don't expect AI to tell you euploidy. I think that's too far-fetched to even hope for. What I'm trying to ask you is, when the embryos are graded, suppose in a situation where people are not very well experienced in judging the quality of the embryo, will it help as an additional tool to identify which one to transfer on that day,
It should.
especially in a fresh cycle?
I hope that it does. Now, yeah, exactly. So that difference will also lie in the fact whether it's a fresh transfer or a
Yes.
frozen transfer.
This choice
Because
is only there at the fresh transfer. Later on
because
you are
the
transferring
because
whatever you
the
will pull out.
embryo quality gets compensated to a great extent during a FET. And the embryo quality, I think, is much more critical during a fresh cycle assessment. And yeah, I have no experience with AI, and I would love to use AI in my laboratory and see if selection with the help of AI would bring about an improvement. If the AI would be able to select better than what we can manually, it would be a great exercise for us to see.
Sir, just to add to that, I think that from my experience, what I feel is the greatest skill of an embryologist is not creating a good embryo, but identifying the embryo which actually can result in pregnancy. And then having a senior embryologist with like Gaurav there, it helps a lot. But when you are having just people who have passed out of their MSc, who have less than 2-3 years of experience, I think any additional intervention which is not invasive definitely can have an impact on that, because that gives some kind of a reassurance, because I work with a lot of very young embryologists with hardly 1 or 2 years of experience, and I feel that confidence they will get if you just give them an AI tool, because when they are just confused between two embryos, AI will give them a numerical score, and that might actually help. But whether it will get translated it into an improved pregnancy, that is something which we have to wait and
No,
see.
I actually believe that it will eventually 100% it will translate into improvement. With the evolution of the technology, I am sure it will.
So to close, anyone want to give a closing remark? Priya, you want to say something?
No, I think I'm just listening to the great discussion. I think I just want to say that to what Manisha was saying is that Manisha, we look at embryos, eggs, everything, but then I think not just us. I think there has been publications which says that the morphology and the grading of the embryo on the day of embryo transfer is what attracts the embryologist more to it. That's what we would choose. However good your early cleavage was, you can check everything. Yes, there is exposure, but then on the day of embryo transfer, what is the best quality grading embryo? That's what an embryologist chooses. That has been the publication. And sir, to you, I think I would also love an AI which will help me choose the best of embryo. We would all love that. Anything that can improve our pregnancy rates, we are happy to have it.
There is one question, Sujatha, in the chat box, which is actually interesting. They're saying that if we receive a A grade embryo on day 6 versus a C grade embryo on day 5, which one would you prefer?
Tina.
Yeah, I can tell as a clinician in our lab, day 6 would be transferred because it's way higher in quality. That's my clinician's.
There was a recent paper, very good paper, which addressed this, and they actually said that a higher grade
Yes.
day 6 embryo would perform better than a lower grade day 5 embryo.
Yes, because between day 5 and day 6, there is not much of a difference in euploidy or aneuploidy in terms of the embryos. It's only on day 7, it actually becomes a little tardier. So if it's a day 6 embryo, which is of a better quality, I think we should go with the day 6.
So, Sujatha, you
What the literature says is, if it is euploid embryo, then there is no difference in pregnancy rate between day 5 and day 6. So
but I can just give you a slight nuance to this. So I used to firmly believe that day 5 embryos are better than day 6 embryos for the longest time. And this is only after this publication I had started thinking that maybe, we can even choose a day 6 embryo before a day 5 embryo. But there are two types of delayed blastulations. One is when on day 5, you have a morula or not even a morula, and these embryos with a proper lag become a blastocyst on day 6. These embryos, in my opinion, are definitely, they are the ones with a poorer prognosis. Whereas you have embryos which are early blastocysts on day 5, and then they become full blastocysts by day 5 end or day 6. These are the embryos which actually do much better. So probably these are the embryos on day 6 which actually do better than poor quality day 5 embryos.
So I think we should close this because, I think we have almost reached 9:30 now. Just to sum it up, see, single embryo transfer is the way to go. But then there are a lot of prerequisites there. You should take it very slowly. Your expectations also have to be, less. You cannot expect 60% or whatever percent of pregnancy rate which you are getting with the double embryo transfer with single embryo transfer. So you have to slowly start with, elective single embryo transfers, because, what happens is many a times when we say what is your result with single embryo transfer, they would just add both the elective single embryo transfer and cases where there is just one embryo for transfer, and they'll put together and say with single embryo transfer, our results are very bad. So I don't think we should do that. We should kind of segregate it. Then embryo selection is the key. You have to have a key, an eye. And, like when you choose an embryo, you have to kind of remember whether it has resulted in a pregnancy or not. Whichever way, you can take picture of it and keep, or you can draw it in your this thing and keep it. So you will know what is the embryo you have transferred and whether it has resulted in pregnancy. That experience would help you to fine tune your skills. Then you have to actually culture embryos to blastocyst, because, without blastocyst, you are not going to even think of single embryo transfer. So I think like how it is being practiced elsewhere, sooner or later, we'll also be there in that stage. With that, I would like to close this session. So Dr. Rajvi, would you be giving the vote of thanks?
Yeah, so basically, I just would like to thank everybody, especially Dr. Shreyas and Dr. Shweta, for coming in. And yeah, Dr. Sujatha, I'd just like to add on two more things. That is a good confidence between the lab, embryologists and clinicians. So I think one of the messages that goes is that what Dr. Shreyas said is let the clinicians also spend time in the lab, little time to know what's exactly happening there. And for the embryologists to look at their data, show their photographs of the embryos, blastocysts to the clinicians. So one, there's the good communication and confidence with each other. I mean, we have confidence with each other, but that would add on. So thank you very much, all the people who spoke, Dr. Priya, Dr. Gaurav, and for the very nice discussion led by Dr. Sujatha with Dr. Shreyas and Shweta. It's too late. So thank you all the audience for joining in, and thanks Aarti for organizing everything. And
Thank you very
Manisha
much
for
for making
coordinating.
us a part of this
Good
lovely.
night, all.
Good night.
Thank you,
and good
Rajni,
night.
for inviting me, and
Night.
thanks
Thank
everybody.
you so much,
Great
everyone.
discussion.
Thank you.
Gaurav, great results. Very impressed.
Thank you.
Thank you so much,
Thank
sir.
you,
And
everyone.
Okay. Bye-bye.
thank